Good morning. We are ready to begin. You know, when I came in today, it was kind of frigid. The weather was frigid outside, but I knew we was coming to the seminar, and we have some hot information for you today. My name is Travis Brown, and again, welcome to the seminar today. I'm a member of the Board of Directors for the Brain Injury Association of Missouri and former principal and director of athletics for the St. Louis Public Schools. I also had the pleasure of serving as president of the Missouri High School Activities Association, that board. Thank you for joining us today for the Brain Injury Association of Missouri Sports Concussion, Facts, Fallacies, and New Frontier Seminar. We will begin the seminar today with a discussion about signs and symptoms of a possible concussion. We will also have an update about concussion-related research and return to play and return to activity guidelines. Then we will have a discussion-related panel discussion. This seminar will be a good basis for our keynote speaker as well, changing your culture in sports. Changing your concussion culture in sports. And again, as I stated, the day will conclude with a panel discussion about concussion case studies. Local and national experts will provide this information to help you recognize and manage potential concussion in youth. And this seminar is free of charge with the support of our sponsors. Let me repeat that. This seminar is free of charge through the support of our sponsors. Our sponsors are the Department of Health and Senior Services, is our co-host sponsor this year. The program sponsor is the Washington University and St. Louis Children's Young Athlete Center. Our statewide break sponsor is SSM Health St. Louis University Hospital. Regional break sponsors include SSM Health Physical Therapy, the St. Louis District Dairy Council, SSM Health Gardner Glennon Sports Care, and Athletico. Please give, again, our sponsors a thunderous round of applause. We're going to play concussion bingo again this year. And during the Know Your Data session, we're going to hear data results from the concussion bingo that you have been and that you will complete in the past years. So be sure to play concussion bingo. At the center of your table, you have the concussion bingo sheet. Could everyone please take this form? As we go through the day, we will share about many of the concussion bingo topics. Other squares you may be able to answer through your current knowledge about concussions. Throughout the day, please complete the squares using the rating for each square ranging from the no or does not currently apply the policy or practice item to 5, which is yes, implementing the policy or practice item 100% of the time. Additional ratings will include 1, meaning implementing less than 25% of the time. 2, meaning implementing between 25% and about 49% of the time. 3, meaning the policy or the practice items are implemented between 50 and 75% of the time. 4, meaning the policy or practice is implemented between 75% of the time. For example, since you have these and you're looking at them, the bottom left square, emergency action plan practice. If your school has practiced your emergency action plan on an annual basis, you will circle yes, which is an indication that your team or your school practice the emergency plan each year. If your team has practiced the concussion emergency plan once in a while, you will circle 1, 2, 3, or 4, depending on what you consider the frequency of the practice. 1 being less than 25%, 2 between 25 and 49%, 3 will equal 50 to 74% of the time, and 4, 75 to 99% of the time. Your feedback from Concussion Bingo will be very helpful, and you can win a prize. During lunch, we will review Concussion Bingo questions that you may not have answered during the session or that needs more clarification. Before the end of lunch, you will turn in the yellow page of the Concussion Bingo form for a chance to win that really, really hot prize. Before we start, we have some housekeeping items. Program evaluations. Those are at the center of your table as well. And there should be enough for everyone. So please look at it, take it now, if you have not already done so. Before we start the first session, please complete the first session of the evaluation form. This is different from Concussion Bingo, and we really, really would appreciate you completing both the evaluation form and the Concussion Bingo. The restrooms. Men's and women's restrooms are outside of this room to your left. You go through the bistro, then to the right of the double doors. And actually, they're easier to find than what I just illustrated. Lunch and break refreshment table is right outside the door. There will also become a lunch table for you as well. You will bring your lunch back inside of the room, and then you will enjoy it. Lunch is also included in the registration. Now, we are ready to begin the seminar. Please welcome a good friend, Dr. Kitty Newsom, Associate Professor with St. Louis University, Department of Physical Therapy and Athletic Training, to kick off our session. Dr. Newsom.
Thank you, Travis. Thanks, Travis. And it's my pleasure to introduce our first speaker of the day. Dr. Hoang is joining us. She is a physician in the Division of Orthopedics and Sports Medicine at SSM Health, Cardinal Glennon Children's Hospital, and at St. Louis University Hospital. You can see from this introductory slide, she is also a team physician at St. Louis University and board certified in sports medicine and in family medicine. And we certainly appreciate her taking the time to come talk with all of us today about concussion facts and fallacies. Dr. Hoang.
Can you hear me with this? Okay. Thank you for having me here. I'm glad to be here. Let me just try to test this out a little. Oh, perfect. All right. So I work for St. Louis University, and I'm one of the team docs there. And I also work at Cardinal Glennon in the orthopedics department, seeing athletes for injuries and also concussion. So I'm really glad to be here to talk to you guys a little bit about what's been going on with concussion. First thing, so all 50 states in the United States have a concussion law. Missouri passed our concussion law back in 2011. There are some three main requirements for the 2011 concussion law. The first is that on a yearly basis, each school district should distribute a concussion and brain injury information sheet to each of their young athletes participating. And the information should be signed by the athlete and or their parents to acknowledge that they have received it and read it. The second thing is that any young athlete or youth athlete who has been suspected of sustaining a concussion should be removed from either the practice or the game at the time and for no less than 24 hours. And along with that is that once they've been removed from the game or practice, they should be, one, evaluated by a licensed healthcare professional who is trained in the treatment of concussion, and also the second thing, receive a letter of clearance returning them to the competition or to game. And if anyone has any questions at any time, please don't hesitate to raise your hand. There have been 5 international concussion conferences where we, in the world, the first starting in 2001 in Vienna. The last actually was November of 2016 in Berlin. So that is our most up-to-date consensus statement on concussion and return to play for concussion. So first things first, this is a facts and fallacies lecture. So first we have to dispel some myths that I have still seen from time to time in clinic. First, there is still some assumption that it needs to be a loss of consciousness in order for a concussion to be considered severe and therefore held out of a game or out of play. Loss of consciousness only occurs 10% of the time. A concussion is a concussion. Any athlete should be taken out of a game or practice immediately, and not only if they have had a loss of consciousness. The second thing is that I still have patients coming in asking whether they need a CT scan or an MRI. CT scan or MRI only looks for bleeding or for any kind of a brain abnormality, such as a tumor or a brain aneurysm that might also be causing concussion-like symptoms. So if there is a concern that there might be a bleed in the brain, that's where the ER will do a CT of the head. The MRI, the only time I do an MRI is if a patient really isn't recovering as I expect that they should, somewhere down the line, and then I may do an MRI in order to make sure and rule out there's nothing else going on that might be masquerading as concussion symptoms. Also, I still hear that, well, you have to wake up the child every couple of hours in the middle of the night, so to make sure that they're not deteriorating. And that's actually really not true. The brain rests and heals the most while it's resting, and so it is okay to let them sleep through the night, and they will sleep a lot, and that is fine. If you every once in a while are unsure, you want to go and just kind of arouse them, make sure they can, they move a little bit, then that's fine, and then you can leave them alone. Helmets, soft or hard, and mouth guards can protect against having concussions. And actually, the research hasn't been able to prove that that's the case. What they really do protect are more serious injuries. They protect against fractures. They protect against dental injuries, lacerations. So more serious injuries than concussions. They don't protect against concussions. And the last myth that I wanted to talk about was that impact testing or any other kind of neuropsych testing is what you need, and only what you need to really determine that an athlete is okay to return to play. Many concussions can be managed without the neuropsych testing. However, these testings, the impact testings, can be very helpful in assisting if it is available in the management of the concussion, but they are never used alone to determine the resolution of the concussion. So what is a concussion? So a very long, complicated definition. So it is a type of traumatic brain injury that is induced by biomechanical forces. It is usually caused by either a direct blow to the head, face, neck, or elsewhere in a body where then the impulse is transmitted to the head. This typically results in a rapid onset of an impairment of neurologic function that then eventually resolves spontaneously. Sometimes the signs and the symptoms can be prolonged, however, and the symptoms and signs can actually evolve and start to present itself within minutes or sometimes hours after the injury. And concussions result in a wide range of symptoms. Not every person has the same symptoms. We hear about a concussion having to have a headache. That's actually not necessarily true, although headache is the most common symptom that athletes usually have from a concussion. And we'll go over that a little bit later in the talk. The majority of concussions do not, like I said before, have loss of consciousness. And typically the resolution of the clinical and cognitive issues with concussions typically follow a sequential course. However, sometimes they can be prolonged. So the physiology behind the concussion basically it occurs when you have either linear or rotational forces that are transmitted to the brain itself. There's this complex cascade reaction that occurs. Basically, there's an imbalance of energy consumption and imbalance of blood supply to the brain. And that's what results in the impairment of the brain function. And what we see is that sometimes some of these changes are more pronounced in our youth athletes. So what are the risk factors involved in concussion? One, if they've had a history of concussion. If you've had a history of concussion, it does put you at a higher risk for having another concussion. Female, It is thought that it could be related to the smaller head neck segment mass, and that way that causing a increased angular acceleration of the head upon a concussive impact. There are some estrogen differences in cerebral blood flow, so that's, these are all kind of things that are being thought of. Could they be a factor in? And there has been talk about some neck strengthening prevention exercises, but these are kind of still up in the air. Also, younger age. Younger age, typically they have a prolonged recovery, a more prolonged recovery. Sport, position, style of play, these can all factor in. In the United States, football, wrestling, soccer, and women's basketball are the highest risk of concussion. Practice, concussions occur more so in practice than in competition. And, one of the reasons that head-down contact and spearing in American football were banned was because of the increased risk of concussion and spinal cord injury. And lastly on here, for those athletes who might have a history of mood disorders or learning disabilities or ADHD or migraines, concussions can sometimes worsen those symptoms or bring them on while they're recovering from the concussion. So now we go to talking a little bit more specifically about concussion in children. So the developing brain is physiologically different from the adult brain. There's less established memory-making pathways, and there's less cognitive reserve. And this is probably the reason why that it takes longer for children to recover from a concussion than an adult. However, that being said, we really haven't adequately studied it in children under 15. But that's the hypothesis. So what are the possible complications of concussion? There are short-term and long-term possibilities. So if we talk about short-term complications, during a concussion, your reaction time, response time is decreased. And so you are putting yourself at a higher risk of repeat concussion or any other kind of sport injury if you're put back into play too soon. Evidence also suggests that premature cognitive or physical activity before complete recovery can make the brain more vulnerable to prolonged symptoms, basically. And this is the most serious complication that we do want to try to avoid. It's called the second impact syndrome. If you are still recovering, or if one is still recovering from a concussion, put back into play too early, and receives a second concussive impact. This is very rare, but in this instance, there's just a sudden loss of autoregulation of the brain's blood supply and the energy demands, and basically the brain swells and herniates, and they die. It's very, very rare. I think back in 2007, over a study of 13 years, there were maybe 94 cases. However, this was studying over high school and college athletes. Only 2 of those cases were in college. So, from a medical standpoint, this is our biggest thing that we, obviously are trying to avoid. So what are the potential long-term complications of concussion? So there's something what we call post-concussion syndrome. This is where I had mentioned earlier about having prolonged symptoms. Can be months, sometimes years beyond the initial injury. We don't have at this point in time a proven cause of post-concussion syndrome, and basically the treatment is time. And a lot of times this also involves a lot of other providers, a multidisciplinary team trying to help the patient with their symptoms. One of the other long-term complications is chronic traumatic encephalopathy. I don't know, have any of you guys seen that concussion movie back in 2015? So this is what they're talking about here. And basically, with this, the repetitive brain trauma causes these, what we call tau proteins, to be accumulate in certain parts of the brain. Those tau proteins are the same type of proteins that accumulate in Alzheimer's. But however, the difference between Alzheimer's and the chronic traumatic encephalopathy is that they're in two different parts of the brain. So just like Alzheimer's, it can really technically only be diagnosed on autopsy because you have to slice the brain and look at it under a microscope to find these proteins. And so the same with the chronic traumatic encephalopathy. But what can happen with this that we see clinically is that you have memory impairment, depression issues, behavior, impulse control problems, executive impairments in reasoning, problem solving. So these, however, are not a continual symptom from concussion. Basically, they happen decades after a concussion has occurred. And we can't tell who's going to have this. With the movie back in 2015, it talked about having repetitive blows. We don't know how many that is at this time, and there's still a lot of research going on in regards to chronic traumatic encephalopathy. And we still need a lot more studies to understand the causes and any kind of prevention strategies for this. The other thing that can happen is chronic neurocognitive impairment. So that is that can present in the post-concussion syndrome. This is where neuropsych testing. So impact testing is a type of neuropsychological testing. There are other neurocognitive testings that can be done to see where an athlete might be having a lot of issues with school and memory and response and recall. That can all be part of this chronic neurocognitive impairment. Some studies show that the more you have these post-concussive blows or concussive blows, you can have an increased risk of developing this chronic neurocognitive impairment. So now that we know why we make concussion such a big deal now, so I wanted to go over the management of a concussion. So first thing, what are our signs of our concussion? There are physical signs, cognitive signs, emotional signs, sleep signs. The two most common are the ones in red, headache and dizziness. However, not everyone has headache. Again, not everyone has dizziness. But some will have balance issues. Some will have sensitivity to light. Some will have sensitivity to noise. Some of them look stunned or dazed. In terms of cognitive issues, kind of feeling drowsy all the time, feeling really slowed down, or feel like they're mentally foggy, forgetful of conversations, just trouble concentrating in school or even concentrating to a conversation. Emotional, a lot of times they get irritable or just kind of more emotional than usual. They might get more anxious than usual or just kind of more depressed as well, especially if they have that history of depression. And then with sleep, it is very common for athletes with concussion to be more drowsy than usual, take more naps than usual, or they might actually sometimes have the opposite and have trouble falling asleep or staying asleep in the middle of the night. So sideline management. Sideline management really is to rapidly screen for a suspected concussion rather than actually having a definitive diagnosis you have a concussion. Players who obviously are clearly manifesting symptoms should be immediately removed from participation, and they can be then taken aside and go through sideline screening with the SCAT-5, which we'll go over that a little bit later. So the SCAT-5 is the most up-to-date. This was released with the Berlin consensus statement. This was in 2016. It actually got published spring of 2017. This is just kind of the cover sheet so that you would be able to recognize it, but you could easily Google it and find the form for the SCAT-5. So with sideline management, the player should not be left alone after the injury and should have serial monitoring, making sure that there is not any sudden deterioration where they might need to go to the ER. And when in doubt, really, if you're not exactly sure, you can always sit them out, sitting them out for 24 hours. So when to go to the ER? If there's any progressive, significant worsening of symptoms or new neurologic signs, if there's a big deterioration in their cognition or their behavior, if there's seizures after the injury, or these other ones are more serious signs of serious injuries, potential spine injury or skull fracture, any kind of blood coming from the eyes or the ears, and any clear fluid that's coming from the nose or the ears, meaning that there may be some what we call cerebral spinal fluid that's leaking. So next, once I see them in the office, what do I do? So the SCAT-5, there's a questionnaire on there. It actually goes over the concussion symptoms that we had just gone over previously, and it asks the athlete to rate them in terms of how severe each one of their symptoms are. And I also do a neurological exam, and then I follow them serially, usually every week to 2 weeks, kind of depending on their symptoms, depending where they are in their season, et cetera. And I follow these serially with office visits. So this is my analogy in the office. I think the biggest thing, most important thing when I talk to the parents and the athletes is educating them on the concussion. So I usually tell them that the concussion is like having a bruise on the brain. If you leave your bruise alone, it's going to heal on its own, right? Your body just kind of heals itself. But if you keep punching the bruise over and over and over again, it's not going to take that amount of time to heal. It's going to take way longer to heal. And it's going to make it worse and hurt worse, right? So it's the exact same thing with a concussion. Activities that can aggravate: TV, light, noise, physical exertion, iPad, computer, tablet, TV, driving, reading. Not all of these affect everyone. So, I get questions of, well, they probably can't play video games, right? Well, I say, well, if it doesn't bother them, I can't say no, unfortunately. But, if it does bother them, then they shouldn't be doing it. Or, a common thing that I hear is, does your phone bother you? No. Do you have to turn the brightness down? Yes. So if you have to turn the brightness down, it is bothering you and you should avoid it. So, as a parent, just kind of being cognizant of that and asking and just reminding the kids is a good thing. So home care. What do they need to do at home? Biggest thing, rest your body and rest their brain. So basically avoiding any activities that increase their symptoms or bring on any of their concussion symptoms that they had listed in their questionnaire. Sometimes in terms of resting the brain, I do have to write accommodations for school, having a note taker or maybe having more time to take tests. And a lot of times, they really can't think and they have to take frequent breaks when they're doing their homework. Sometimes not more than 10 minutes at a time that they can do work. Basically, usually I tell them to do work and they have to stop and take a break before they get to the point that they develop symptoms, because then that's like punching their brain. So I will write those accommodations. And sometimes, they have headaches before they even get to school. So then I do write them out for school. And, I write them out for school depending, basically until they're symptom-free at home, doing nothing, and then slowly working back into school. Tylenol is typically the preferred medicine for pain after this type of injury. However, that being said, I usually say for a severe headache, you're having a lot of trouble, take it. But if your symptoms aren't that bad, you're probably doing something that's aggravating it. I would try to avoid it because it's a pain medicine, right? So it takes away pain. So then the athlete is not sure what they're doing, that's aggravating it because they have this pain medicine on board. And the reason why we say acetaminophen or Tylenol before, rather than ibuprofen or Aleve, that technically in the first 48 hours, Aleve or ibuprofen or Motrin or Advil, they all can thin the blood technically, and so you can increase the risk of, technically, of, brain bleeds, in the first 48 hours, if there is a bleed present. Also, getting a lot of sleep, eating well, are all factors in terms of getting better. So how long does it take to recover? Typically in adults, we see 7 to 10 days, 2 weeks. Children's likely longer. And honestly, in my experience, it's not uncommon for me to see 3 to 4 weeks. Not uncommon. But everyone is different. So there's really no set timeline. So that's why I usually see them every week to 2 weeks. So what is the role of neuropsych testing? So there are a lot of different companies and a lot of different tests. CogSport or Axon, there's a HeadMinder impact test. They're all a little bit different. Some you have to pay fees for, some you don't have to pay fees for. They are all used to assist in the decision making of when I feel that they're ready to return to school or return to sport. It works best if there is a baseline, so preseason, completely asymptomatic testing. But however, again, like I said previously, it's not the sole determinant of when the athlete is ready to return to play. So some school districts are, have this available, but not all. So a lot of the times, especially when I'm seeing high school kids, I don't have this available. So returning to school, there's no standard guidelines. We had talked about academic accommodations, and basically I don't let students return to sport unless they're back to their academic baseline, because sport requires more energy and increases the blood pressure. Blood goes to the brain, so then increases pressure in the brain compared to sitting on your bottom and studying. So when do I let them return to sport or play? Once they've had a symptom-free period, as well as a back to normal neurological exam, they're able to start the return to play. And then, so how long is a symptom-free requirement? Honestly, it really depends on, how long they've been symptomatic for. For a kid that maybe has been symptomatic for longer, maybe like 2 months, I'm gonna make them have a longer symptom-free period compared to someone whose symptoms probably resolved over 2 weeks. But again, no specific guideline on that. So this is a return to play protocol. There are 5 steps. Each step is 24 hours. So the first step was, light aerobic activity, less than 70%. Usually I say like stationary bike, for example, for like 15 minutes, and they stop. And if they don't have any symptoms during or the rest of the day, then the next day they get to go to step 2. And step 2 is adding movement in. Step 3 is adding some exercise, conditioning, some increased mental thinking. Now, if they have symptoms, then they need to stop for 24 hours. And then once that 24-hour rest is up, they can restart at the last step where they did not have symptoms. So for example, if they are on step 3 and it's Wednesday and they have symptoms, so they need to stop. Nothing to do on Thursday. Friday, they get to start at step 2. And then they keep moving up. Now, my recommendation is that the return to play protocol be done by a supervised athletic trainer if an athletic trainer is available. So what is your role? You are the first source of information. Administrators, school nurses, athletic trainers, you guys, coaches, are the biggest part in the student athlete's health and the safety. And usually you're their first source of knowledge on topics like concussion. So really having some preseason education about this, about signs and symptoms, and that it is a big deal, that that they shouldn't just hide it and try to go back in. I actually had recently I saw one of the college athletes in town for one of the other colleges, and he has history of, I don't know, multiple concussions. And last year during basketball season, he had a concussion, had symptoms for like 2 months, and then he said, so I started kind of going back. But he still had symptoms when he went back. And a year later, he's still having symptoms because he kept going, even though he didn't stop and really didn't allow him this time to recover. So obviously I took him out, and he's not playing currently, and we'll see how he does. And the biggest thing is when you're in doubt, if you're like, well, I'm not sure, maybe, just sit them out. Sit them out for 24 hours, and if they're completely fine the next day, so put them back in. But then, that saves them rather than having prolonged symptoms or increasing their symptoms from the concussion. So the CDC has a really great, is a really great resource. And actually, so if you Google or go to CDC website and just put Heads Up Youth Sports, there's a whole page on it. You can do there's a training module, like a video training module that's like, I think it's like less than 30 minutes that you can do on it. There's information for coaches, parents, there's officials on there. And they actually have a lot of even handouts that you can give to parents or coaches, or and you can even, I think you can adjust your school logo or your school colors on these forms, just as a resource. So looking at what are the potential signs of a concussion? When should I think, maybe I need to sit this kid out? If there's any kind of loss of consciousness, if there's any kind of balance or motoring coordination, any kind of disorientation or confusion, the inability to really kind of respond, like slow to respond to any answers, respond with answers to any questions that you might have, repeating questions, 2 minutes later, any kind of loss of memory, kind of blank or vacant look, or obviously any kind of facial injury with a combination of the above. So there is a validated questionnaire called the Maddox score, or for children between 5 and 12, it's the Child Maddox. This is actually on the SCAT form as well, on the first or second page, and it just kind of some simple questions. If they answer yes, or they know all the answers to all of them, the likelihood of them having a concussion is low. So this is kind of part of some sideline quick management. So what are some of the signs that coaches might see, parents might see, and some of the symptoms reported by athletes? So this I actually took from a wallet card that the CDC has on their Heads Up website for concussion management. And obviously you can read on your handout. And this is a copy of that. That's obviously very blurred, but that's what it looks like. So, notifying parents. Athletes should be removed from practice or the game immediately and shouldn't return to play for at least 24 hours. And then the athlete should be evaluated by a licensed healthcare professional that is trained in the management of concussion. So, a lot of times, so sports medicine physicians will be trained in this and will be very familiar with this. Some pediatricians and some primary care docs are trained and comfortable in dealing with this, but not all. So, if there's always, any questions, you can always see one of the sports physicians in your area. And an athlete should receive written clearance to return to competition from that healthcare provider. So this is an information sheet that you can find that is for parents on that website. And then some educational websites, CDC I had mentioned. The NFL also has this concussion program and a lot of information on there as well too. And that's it. So. Are there any questions? Yes.
What do you do when parents refuse to take them to the doctor? Or you're asking for a clearance letter and they don't have the money or they don't want to take them and they just want to give their verbal clearance?
Oh, the question was, what do you do when parents refuse to take their child to the doctor? That they don't have money to take their child to the doctor? I don't know, because I'm always on the other end, honestly. I mean, you can pull, I mean, it's a Missouri law that they have to be seen by a physician and released by a physician. You know, that's the Missouri law since 2011. You can say, you know, by law, you can't let them back in. There are some schools, like, so I've had kids come in with forms from the school and district that they actually have to have a, it's actually a release form if they've had a concussion, and they're not allowed back in. And the trainers give it to them until they have this form filled out. Now, I've seen kids where really they don't have a concussion. They come in, and so I just fill it out that day and then send them back on their way. But then that form for if they have a concussion, I fill that out, and then I have to fill it out every visit after that. So you can put the law behind you. I don't know if anyone's going to go after them.
May delay their return.
Oh, yes.
You said part of your evaluation for release,
Yeah.
put an athlete back in the sport. You mentioned it depends on where they're at in the season. What did you mean, or can you clarify that as far as where they're at in the season as far as your evaluation?
Oh, so then I must have misspoken. So that was in terms of part of their season is if they've had prolonged symptoms and their symptom-free period in terms of when I return them back to play.
In other words, don't take it as early season, late season, you know, somewhere in the season. I guess as a coach, you would think, okay, how important is it? Early season, late season. That's
No.
what I heard.
Sorry.
I wanted to clarify that. Like,
Yes.
shouldn't make a difference, I guess.
No, it does not make a
Okay,
difference.
thank
We're
you.
in season, they are.
So in our school, we don't give Tylenol right after a head injury because we are trying to make sure that they don't develop any symptoms. Is that still the case, or should we treat with Tylenol right away?
No, I don't think you necessarily need to treat with Tylenol right away. But, you know, once they go home and they're having bad headaches, because initially, especially at the sidelines, you want to know if they're deteriorating, right?
Yeah.
So, but in terms of the Tylenol that I'm talking about, because I guess I do it from a physician office standpoint, usually once they go home, if they're needing Tylenol, then you can take that.
Thank you.
And then there was a question up here.
Probably the most common thing I run into, and it's something I struggle with at times to talk to the parents about, is if there's an athlete that sustained a blow to the head and only has a headache and is absence of all the other symptoms, you know, balance is okay, vestibular looks okay, the only thing they have is a headache, explaining to them whether it's a concussion or not, because they'll say, well, you get hit in the head, of course your head's going to hurt.
Yeah.
But a headache, does that make it a concussion? What would be your
So,
guidance on that?
So usually when I see these kids in follow-up, and you know their headache goes away like a couple hours later, it's not a concussion. But, if it's more than obviously 24 hours, then it is a concussion, and that's their only concussion sign. However, you can't tell that in the beginning, and the symptoms can evolve, and they can have more symptoms that may develop maybe 30 minutes later, a couple hours later, later that night, a lot of times. So, I guess in terms of, so what do you tell the parents? You can tell them that concussion symptoms may evolve over several hours, so we just need to be safe and keep them out for at least 24 hours and see what happens. That might be helpful. And I do have to say, I do have kids lie to me when they first come in, obviously, that they're really, their symptoms. But, on my exam and my neurological exam, my physical exam, I obviously can tell, and that's why I do that. And then I go through the whole spiel, and then they see me a week or two later, and they go, yeah, so I kind of lied to you. Yeah, so do you feel much better now that you've rested? Yeah, funny how that works. So, anyways, any other questions? Yes.
Are two back-to-back concussions considered different from second impact syndrome?
Yes. Two back-to-back, the question was if two back-to-back concussions are different from second impact syndrome. It is. Second impact syndrome is a specific, thing that occurs where on that second impact that this brain swelling occurs. But that is when usually when they've returned to play while they still have concussion symptoms. So it's a second impact on a still symptomatic concussion. Whereas two back-to-back concussions is a concussion, completely recovered, and then another concussion. So I've had it where, I've had kids have, a concussion 6 weeks ago and get another concussion, but that's not second impact syndrome. Any other questions? Okay. Well, thank you for having me.
Thank you for sharing this information with the audience. And for many, may have been a great refresher, and for quite a few, a good introduction and a nice basis for the rest of the day. On behalf of the Brain Injury Association, I want to thank you for your time and
Thank you.
a token of our appreciation.
Thank you so much.
Thank you very much.
Glad to be here.
Good morning. Is it on? Okay. My name is Dean Anderson. I'm the coordinator of the state's traumatic brain injury program, and it's my pleasure to introduce our next speaker. I was going to quickly, though, address if you don't have insurance and your kid has a TBI. We have done educational outreach into the local public health association, so all of your local public health organizations should have some information on TBI. We've got great information online as well, and they could be able to push that information out to parents who don't have insurance if they go see their local public health association and try to access information about TBI that way if they could. So I just thought I'd put that little plug in there for your local public health. But if you haven't heard our next speaker, his name is Dr. Mark Halstead, and I think you're in for a treat. Dr. Mark Halstead is the director of the Youth Athletic Center with Washington University and the state St. Louis Children's Hospital. He is an international expert, and we are honored to have him present on brain injury for the Brain Injury Association this year. So if you could give him a warm hand of applause, we'd appreciate it. Thank you.